What is the added cost, would you think, to somebody saying, if I want to perform this, what is it going to do from a financial standpoint?
Well, let's talk about startup costs for the clinician and the clinical team first. Of course, you'll need the planning software, which is approximately the same as the Implant Pro software. There are a couple of other planning softwares that are a little bit less, but of course you'll need that. With this system, because we're going through the Nobel Guide itself, we need a kit of instruments which are very well developed for the shape of the implant body that you want to work with. So for example, if you want to do a Bradamart style implant, there is a specific kit that's created that has approximately 10 millimeters longer on all the drilling elements to allow for the placement through the actual guide. Right. Same thing, if I do a lot of the replace system tapered, and there's a kit specifically for that. There's also a replace straight, which requires another kit. So you can have one kit up to 3 or 4 types of kits in your practice, and it depends on how many cases you're doing. So the kit and the startup is basically training, the kit, and the software. There are bundled together offers by the company where you can buy the kit and the software and get a training program thrown in. The training programs vary from $2,000 to $3,000 depending upon which center they're teaching them, and they're generally a day to a day and a half in length. Some have a demonstration, some have a video demonstration, and some spend a lot of time on model workshops and or the use of the computers.
Did you do this course in your,
yes,
in your teaching center?
I have a training center in Boca Raton where I do 2 basic courses, a 1-day software course, which is really geared for an experienced clinician that can just look at the kit and understand the steps. So they don't need to be watching me do a live surgery demonstration. They need to learn the software planning. Those courses have been phenomenal. Everybody that's left that course has planned at least 3 cases independently of me. We do a couple of teaching ones.
Their own cases?
No, not necessarily their own, but we have demonstration cases that everybody uses. We have computers,
and
terminals.
There, everything's already set up for them.
So I do one in general, I do one with them step by step, and then we do another 1, 2, or 3, depending upon how the pace is going, and everybody pretty much learns what to do.
Jack doesn't know this yet, but he's going to be doing one of these courses next year at the Dental XP Center in Atlanta, and we're really glad to be having you there.
I couldn't wait to do it, and it sounds like a great idea. I'll just have to go through all the pre-steps. I'd like to tell the group that there's a little bit of a misnomer. One of the terms used with this concept is teeth in an hour. And I could assure you that the surgical phase and the prosthetic phase will take maybe an hour, maybe even less. But do not think that your patients are walking off the street and getting it done in an hour. We do rigorous pre-planning. My restorative teammates get the exact fits. They work a lot on the bite, the contours. All of these things are going to be transferred into the software program, which will get to the outcome. We would hate to have a prosthesis that's a final prosthesis that the patient says, I want the teeth longer, I want an angle, the shapes are wrong.
So basically the pre-prosthetic stages are always the same. You need to have the wax up, the surgical guide, the radiographic guides. All of that pre-prosthetic information is always needed before you start the procedure, then going to the CAT scan, and then going through the process of planning the case. What was mentioned earlier was this has been predominantly, at least originally, made for the dental handicap patient, fully edentulous. Today, people are starting to use it in the partially edentulous patient, and I want to give the people in the out in the audience here whether or not that's something that you've started to do. How often would you do a partially edentulous patient? How many teeth? And what are the critical factors in dealing with them?
Yeah, that's an excellent factor, and it actually goes right back to what we were talking about with the pre-planning.
Right.
I'd like to first remind everybody that when we first started doing osseointegration, it was a discipline really developed for the totally edentulous patient. The instrumentation was a little bit bulky. It was, all the trials were done on those types of patients, and this is very similar to that. The early entree of this Works beautifully on a totally edentulous case. The instrumentation is well developed and well thought out. However, in my practice as a periodontist, probably more of my cases are partially edentulous designs. Now, if I'm having a two-tooth gap for implants, you could do this method, but it may not be really necessary. Just because you can do it, it's maybe a little bit too time-consuming. My teammates and I can create standard model-based guides. And with Nobel, we have the rings we could use, and we can actually make a model-based Nobel guide using their guide sleeves and the kit. So there's ways of implementing that. If it's like a hemimandible or a hemimaxilla, those are great cases to consider because we can modify angles in advance. Our teammates will know whether we're going to be using custom abutments, the pre-angulated components from the manufacturer, requiring us to position the tops of the implants exactly where we want by using the little dot on the mount. So there are a lot of versatility things available. What I think is critical, and it's not specific to the Nobel, it's with all of the CT techniques, is the concept of radiographic scatter. If a patient has alloy restorations or crown and bridge restorations, there's just a radiographic burst or like a starburst pattern called scatter. And there are tools in the program that we use to cut out the scatter so we can do the planning. So if I had a case, let's say, that had teeth in the premolar and the molar of one side and the anterior and the other arch are without teeth, we could create a proper pre-prosthetic and radiographic scanning device with high flanges, with the radiographic markers ideally where we want, and a polyvinyl siloxane bite that will allow the patient to get a scan done properly. Now, if there is some flash from the other side, we can very easily cut that out of the field that we're working on in the software, and take the design prosthesis that we created before we even started the technique. With good flanges, we can get the anchor pins positioned properly. It shows up nicely in the planning software, and we get the angulations and the positioning of the implants. So yes, we're doing it on partially edentulous cases. Personal preference, I would say a 3 to 4 tooth gap would be where we would start wanting to use it. Otherwise, the gaps are too small, and we could use conventional guides. They work beautifully.